Okay, let's unpack this. Imagine you're a nurse, diligently caring for Mrs. Lee, an older patient who just moved here from Vietnam. She's complaining of terrible headaches and fatigue, but every time you ask about her mood, she just smiles and changes the subject, or maybe says her family will handle things.
Right. You're trying everything, using all your skills, your empathy,
Yeah.
but something's just not connecting.
Exactly. You start wondering, what am I missing here? Welcome to the deep dive. Today, we're taking a really close look at cultural implications, a vital section from Varkarolis's Foundations of Psychiatric Mental Health Nursing.
Yeah, this is foundational stuff.
Our mission here is basically to equip you with the essential knowledge and, practical insights to bridge those kinds of cultural gaps, to help you provide truly patient-centered, culturally relevant care, especially in psychiatric mental health setting.
Because in our world today, which is becoming so diverse,
Mm-hmm.
understanding culture isn't just like an extra thing. It's absolutely core for every nurse.
Yeah.
And that's precisely why this deep dive is so critical for future nurses like you listening. We'll explore everything from how deeply culture shapes our understanding of mental health and illness,
Mm-hmm.
all the way to concrete assessment tools and intervention strategies you can actually use.
So this will directly enhance your clinical decision-making.
Definitely. It helps you navigate those complex patient interactions with, well, more confidence. And it prepares you for your real-world nursing responsibilities and, yeah, even for your NCLEX exam.
Okay, good. So let's start by clarifying some foundational terms. These words, they get thrown around a lot, sometimes interchangeably.
Yeah, me too.
But for nurses, really understanding the distinct meanings is essential. First up, minority status.
Okay.
Now, this isn't just about being, a smaller number of people within a bigger group.
Right, that's a common misconception.
The core insight here really is that it's about power dynamics. It highlights a socially defined group that's often socioeconomically disadvantaged, maybe lacking power, and because of that, susceptible to discrimination. It's a critical blind spot if we just think about percentages.
That's a really important distinction. Power.
Then we have race. Now, for our context today, race is basically socially defined. Think about how the U.S. Census Bureau handles it.
Right, the self-identification part.
Exactly. Individuals first self-identify maybe as Hispanic, Latino, or Spanish origin, and then they specify their race from a list of choices or even write something in.
And a key purpose for collecting that data, at least officially, is to identify healthcare disparities, where certain groups might be getting underserved.
Right. Okay, next, ethnicity. This is more about a common heritage and history, wouldn't you say?
Yeah, exactly. A shared worldview that guides beliefs, values, practices is about the traditions, the stories, the shared background.
Got it. And central to our whole discussion today, culture.
The big one.
Yeah. This is the shared beliefs, values, and practices that truly guide a group's thinking and acting. And it's incredibly broad, isn't it?
Oh, absolutely. It covers religious beliefs, geography, socioeconomic status, job, ability or disability, sexual orientation, all those beliefs and behaviors.
And for nurses, this is the really critical takeaway. Culture, this shared way of thinking and acting, is what should guide your patient care, not just these big, broad labels like race or ethnicity.
It's like the blueprint for how a patient understands health, illness, everything.
Right. And finally, cultural norms. These are sort of the invisible rules.
Yeah, the attitudes and behaviors considered typical or normal within a specific group. They really help define what's seen as mental health and what's seen as illness within that culture.
Okay.
What's truly fascinating here is how making these careful distinctions really moves us beyond simple labels. It helps us understand the complex blueprint guiding a patient's actions related to their health rather than just making assumptions based on one identifier.
So it's about respecting the complexity. Like with Mrs. Lee, understanding maybe why she doesn't discuss her mood directly.
Precisely. It's respecting that rich tapestry of human experience.
And speaking of that tapestry, think about the huge demographic shifts happening in the United States. Projections show the U.S. population is becoming a majority-minority nation, maybe around 2043.
Yeah, meaning no single group will make up over half the population.
Right, like non-Hispanic white populations are projected to decline significantly as a percentage by 2060, while Hispanic and Asian populations are growing fast.
Which just hammers home the point, doesn't it? The critical, absolute need for every single nurse to develop real cultural competence.
Couldn't agree more. Okay, here's where it gets really interesting, I think. Our understanding of mental health in the US, it's so deeply rooted in the Western tradition.
Oh, absolutely. It permeates everything.
But how do other major worldviews contrast with that? Let's try to unpack three basic worldviews mentioned in the text.
Okay, let's do it.
First, the Western tradition. It's got roots in Roman, Greek, Judeo-Christian thought, and the Enlightenment. Especially Descartes, right, that mind-body split idea.
Yes, the famous dualism.
So here, identity is really found in individuality. Things like autonomy, independence, self-reliance are highly valued.
Right. The mind and body are seen as separate things, often treated by totally different specialists.
And disease. It's believed to have a specific measurable cause. Time is seen as linear, moving forward, future-oriented, and ethics are often based on individual rights and obligations.
That probably sounds pretty familiar to most of us listening.
Yeah, it's kind of the default setting in our healthcare system. Now contrast that with the Eastern tradition. This is influenced more by, say, Chinese and Indian philosophers, Buddha, Confucius, Lao Tse.
Very different philosophical grounding.
Here, the family is often the basis for identity. Interdependence and group decision-making are the norm, not individuality.
And crucially, body, mind, and spirit are seen as a single, unified entity. There's no real separation there.
Right. Time is often viewed as circular, recurring. You see beliefs like reincarnation fitting in here.
And disease isn't necessarily about a specific cause in the Western sense, but more about a lack of balance. Think yin-yang, for example.
And ethics. They tend to emphasize promoting positive relationships, care, compassion, fidelity.
This might help explain, going back to your example, why Mrs. Lee might prioritize her family's role in her health decisions or talk about balance.
Exactly. Then there's the indigenous culture worldview. Often a deep, profound connection with nature is central here.
Very much so.
Identity is frequently tied to the tribe or community. The concept of a person existing in isolation might not even really make sense.
And that unity of body, mind, spirit, it's often so complete that there might not even be separate words for them in the language.
Wow, so disease might be seen as a lack of harmony with others or with the environment. Even thoughts and words are sometimes believed to literally shape reality.
And time often focuses much more on the present moment, rather than the linear future focus of the West. Ethics are typically based on the needs of the community as a whole.
So if we connect this to the bigger picture,
Yeah, it becomes really clear how these fundamentally different philosophical foundations shape everything: perceptions of reality, health, illness, social roles.
and that directly impacts how patients, like maybe Mrs. Lee, perceive and interact with our healthcare system, which is mostly Western.
Absolutely. For nurses, understanding these basic differences, like why a patient might prefer traditional remedies or involve their whole family in decisions, is just key to providing effective, respectful care.
Okay, so culture isn't just some abstract idea. It really impacts daily interactions in profound ways. Let's talk about nonverbal communication.
Oh, this is a big one. So many misunderstandings happen here.
For example, eye contact. In the US, we usually see direct eye contact as signaling attentiveness, honesty, right?
Right.
But for someone like Mrs. Lee, perhaps, or in many other cultures, avoiding direct eye contact might actually be a sign of respect. Making direct eye contact could be seen as rude or even challenging.
Imagine that. A nurse trying hard to build rapport, but unknowingly offending the patient just by looking them in the eye in a way that feels normal to the nurse.
Or think about personal space, how close people stand. U.S. norms are sort of in the middle, but in some cultures, like maybe Middle Eastern or Latin American, people stand much closer. In others, maybe some Asian cultures, they maintain more distance.
And it's easy to misinterpret, isn't it? Mistaking closeness for aggression or maybe distance for coldness or disinterest. It can completely derail an interaction before it even starts.
Totally. Then there's etiquette. This covers a huge range of things. Punctuality, how formally you address people.
Showing respect, social touching, shoes in the house, modesty.
Accepting or rejecting hospitality, how long you make small talk. Being direct versus subtle.
Even tone of voice, pace of speech, taboo topics, touching children.
Mhm.
It's all culturally patterned.
Right. Think about Mrs. Lee again. If she arrived late for an appointment, it might not be a disrespect. Maybe it's a different cultural norm about time, or maybe just the practical difficulty of figuring out a new bus system.
Or if she seems to avoid small talk, maybe she's actually showing respect by trying not to waste what she sees as your valuable time.
Understanding these subtle, unwritten rules is just vital.
Absolutely.
And of course, underlying all this are beliefs and values. The dominant U.S. patterns often emphasize things like individualism, independence, competition. maybe materialism.
Mastery over nature, an internal locus of control, like I am in charge of my destiny in that future orientation we mentioned.
But in many other cultures, you find very different patterns. Maybe familism, the family unit being primary interdependence, social hierarchy being important, respect for age and wisdom.
Cooperation valued over competition, spirituality playing a larger role, striving for harmony with nature rather than mastery over it, perhaps an external locus of control feeling things are influenced by fate or outside forces, and maybe more of a present or past orientation.
So, for Mrs. Lee, decision making might naturally involve her whole family, not just her as an individual.
Precisely. And these differences show up starkly when you look at health and illness perspectives.
Yeah, the text has some great comparisons. Like, health in the US is often just seen as the absence of disease or being able to function at a high level.
Whereas in other cultures, it might be defined more as a state of balance or harmony, or simply the ability to fulfill your family roles.
Disease causation. In the US, we look for that specific, measurable cause. Elsewhere, it might be seen as something intangible, a lack of balance or harmony.
Location of the disorder, too. U.S. tends to locate it in the body or the mind. Other views might see it in the whole person, or even involving the family or the environment.
Who makes decisions about care? In the US, it's usually the patient or their designated power of attorney.
But elsewhere, it could be the whole family, or maybe the head of the family makes the final call.
Even the sick role differs. US often values independence, self-reliance, even when sick.
Whereas in other cultures, the expected role might be more passive, with the family stepping in to take care of the person completely.
Best treatments. US leans heavily on physician-prescribed drugs, technology.
Other traditions might prioritize regaining that balance or harmony, perhaps using folk healers or traditional remedies alongside or instead of Western medicine.
And pain, that's a big one.
Stoicism is often valued in the U.S., reporting pain quantitatively, like on a number scale.
But in some other cultures, more vocal or dramatic expression of pain is common and completely expected. It might be experienced more globally, less localized.
So this could be why Mrs. Lee's headaches are maybe discussed in terms of an internal imbalance rather than demanding a specific diagnostic label or pain score.
Exactly. And all this really raises an important question. How does our own cultural lens, our ethnocentrism, prevent us from truly seeing the patient's reality?
Right, we all learn our culture's norms through enculturation, don't we? We learn what's right or normal from our families, our communities, without even thinking about it. Yeah, we just assume our way is the way. So when you encounter something different, like maybe a culture where speaking in tongues is seen as a genuine religious gift.
Well, someone from another background might immediately, mistakenly think psychosis.
It highlights the danger, doesn't it? Our own cultural norms can genuinely blind us to what's really going on for the patient, like potentially misinterpreting Mrs. Lee's reluctance to discuss her mental health or her focus on physical symptoms.
Okay, so despite our best intentions as nurses, several pretty significant barriers can get in the way of providing effective care for culturally diverse patients. It's really critical we recognize these.
Absolutely crucial.
First, and maybe biggest, communication barriers. This is just paramount, especially for patients like Mrs. Lee who might have limited English proficiency.
Cannot emphasize this enough.
Healthcare organizations must offer professional interpreters, and importantly, at no cost to the patient.
Yes. And ideally, these interpreters should match the patient in things like gender, age, social status, maybe even religion. Impossible, inappropriate.
And they're not just translating words, are they? They should act as cultural brokers.
Exactly. Interpreting not just the language, but also the nonverbal cues, the cultural nuances, the underlying meanings. This is vital information for the nurse.
This isn't just something to know for the NCLEX, your licensure exam, though it is important. This is about safe, effective care in every single interaction in the real world.
Couldn't agree more.
And, crucially, the text stresses why relatives or friends should generally not be used as interpreters, especially in psychiatric settings.
Right. There are several reasons. The stigma around mental illness might prevent the family member from being fully open, or they might try to soften things.
Plus, they often just lack the precise vocabulary for complex emotional nuances, and literal translations can completely miss the meaning of idioms like feeling blue might mean nothing if translated word for word.
Using untrained interpreters is really risky.
Okay, another major barrier. The stigma of mental illness.
This is a global issue, sadly.
True, but it's often much more severe in cultures that really emphasize family interdependence. In those contexts, mental illness can be seen almost as a family failure, bringing deep shame.
Which often leads to delaying treatment, doesn't it? People might only seek help when the problems are incredibly advanced and impossible to hide anymore.
That could definitely be contributing to why someone like Mrs. Lee might present with vague physical complaints first, rather than talking about mood.
Makes sense.
Then there's the very real risk of misdiagnosis.
Yes, studies have shown this is a serious problem. For instance, there's a significant risk for Black and Latino Hispanic Americans being misdiagnosed with schizophrenia when the actual issue might be bipolar disorder or another affective disorder.
And a key reason for this is the use of assessment tools that are culturally inappropriate, maybe validated mostly on people of European origin.
Exactly. The tools themselves might have a cultural bias built in.
A really fascinating example related to this is somatization.
Ah, yes. Experiencing psychological distress as physical problems.
Right. Like Mrs. Lee describing her back pain, fatigue, dizziness, but never mentioning feeling sad or hopeless. If a nurse isn't culturally aware, they might completely miss the underlying mental health issue and just focus on the physical symptoms.
Which leads to ineffective treatment, of course.
Fortunately, the DSM-5, that's the Diagnostic and Statistical Manual of Mental Disorders, now includes the Cultural Formulation Interview, or CFI.
Yes, that's a really helpful tool.
It's basically a set of 14 questions designed to help clinicians understand the patient's perspective, their cultural orientation, values, assumptions about their illness, family support, coping styles, what they expect from care. It helps tailor the treatment plan.
It encourages a more person-centered approach.
The DSM-5 also talks about cultural concepts of distress. This is an umbrella term for a few things. One is cultural syndromes, which used to be called culture-bound syndromes.
Right, these are clusters of symptoms that are recognized as patterns of illness within specific cultural groups, often with distinct local names.
The book gives examples like attack de nervios, seen in some Latin American cultures. It involves sudden trembling, palpitations, dizziness, maybe loss of consciousness, often linked to things like evil spirits or just intolerable stress.
And often treated by spiritual healers within the community. Another example mentioned is wind illness or cold illness in some Chinese and Vietnamese cultures, a fear of cold, wind, or drafts thought to cause illness due to an imbalance of yin and yang.
And they have traditional treatments like coining or cupping to address it.
There are also cultural idioms of distress, specific ways of talking about suffering within a culture, like saying I'm a nervous wreck, and cultural explanations, which are the culturally based ways of understanding the causes or nature of symptoms or illness.
You know, it's kind of surprising when you step back. We tend to think of these cultural syndromes as, well, strange or exotic.
Yeah.
But then the text points out that some disorders listed right there in the DSM-5 might seem equally unusual to people from other cultures. Things like anorexia nervosa, bulimia nervosa, binge eating disorder.
That's a great point. They are arguably Western culture-bound syndromes, deeply linked to the intense value placed on thinness, particularly in European and North American cultures.
It really puts our own cultural lens into perspective, doesn't it?
Definitely does.
Okay, one last barrier area, genetic variation in pharmacodynamics.
Right. Basically, how a person's genes affect their response to medications.
We know drug responses can vary significantly based on genetics, but the problem is clinical trials for many drugs historically haven't included very diverse populations.
So the standard dose might not be standard for everyone.
Exactly. Our bodies have these enzymes, like the cytochrome P450 or CYP enzymes, that metabolize most antidepressants and antipsychotics.
And there are genetic variations in these enzymes. Some people might be rapid metabolizers. The drug gets broken down too quickly, levels are too low, it doesn't work well.
Or they could be poor metabolizers. The drug builds up, levels get too high, leading to more side effects, even toxicity.
And now, genetic testing, pharmacogenetics, is actually being used more often to help predict how someone might respond and guide medication choices and dosages. This could be really relevant for someone like Mrs. Lee's treatment plan.
So when you put all these potential barriers together,
Yeah, it raises that important question again. How profoundly can misinterpretations, whether it's communication, stigma, misdiagnosis, or even these genetic differences, lead to really ineffective treatment, frustration, and maybe even further distrust in the healthcare system?
it's not just theoretical stuff for nurses.
No, it's about patient safety, building trust, that therapeutic alliance. It's core to our practice.
Okay, let's talk about some populations that face unique challenges, making them potentially more vulnerable to mental illness and maybe not getting the care they need. Consider immigrants, like Mrs. Lee in our example.
Right. They arrive, often don't speak the language fluently, and have to navigate completely new systems, economic, legal, healthcare. It's overwhelming.
And many who might have had high status or respected professions in their home country find only menial jobs available here. That loss of status can lead to significant anxiety, depression.
Yeah, it's a huge adjustment.
Yeah.
And we see concepts play out like acculturation, the
Mhm.
process of learning and adapting to the new culture. Sometimes it's assimilation, where the old worldview is rapidly absorbed by the new one.
Or people become bicultural, learning to move between their original culture and the new one. And almost everyone experiences some degree of culture shock,
And within families, there's often intense intergenerational conflict. Kids usually pick up the new language and cultural norms much faster than their elders.
which can challenge traditional values and create a lot of tension. Imagine Mrs. Lee's grandchildren having very different ideas about healthcare or family roles than she does.
It adds another layer of stress.
Then there's a special category, the refugee. Unlike immigrants who generally choose to leave, refugees have fled intolerable conditions, war, torture, genocide.
Their experience is marked by profound trauma and loss. They haven't just moved, they've often lost everything: home, possessions, family members, their sense of safety.
Which makes them highly vulnerable to conditions like major depressive disorder and especially post-traumatic stress disorder, PTSD. Their needs are often very complex.
Absolutely.
And then cultural minorities more broadly within a country. These groups often face systemic issues like poverty, limited educational or job opportunities, bias, discrimination, racism.
Yeah, those social determinants of health have a huge impact.
And the text makes a really important point here. While the overall prevalence of psychiatric disorders might be similar between minority groups and whites in general, it's significantly higher for those cultural minorities living below the poverty line.
So it's not the race or ethnicity itself that's the primary driver.
It's the poverty, the socioeconomic disadvantage, the stress associated with that, which is the key risk factor for higher rates of mental illness in these populations.
These disparities really underscore why cultural competence isn't just, a nice-to-have skill for nurses. It's a fundamental ethical requirement, a practical necessity for providing equitable and effective care to all patients, including those most vulnerable, like Mrs. Lee might be.
Okay, so how do we actually do this? How do we provide culturally competent care? The U.S. Department of Health and Human Services defines cultural competence pretty straightforwardly. It's the ability to work effectively in cross-cultural situations.
Right, being able to adjust your nursing practices to meet patients' cultural beliefs, their specific needs, and their preferences.
And this brings us to a really useful model by Campina Bucco, the process of cultural competence in the delivery of healthcare services.
Yes, it's a widely respected model in nursing. And the core idea, which I really like, is that cultural competence isn't a destination you arrive at. Nurses are always becoming culturally competent.
So it's a lifelong journey.
Exactly. A continuous process of learning and growth, not a fixed state you achieve. It fosters this mindset of humility and openness.
Okay, let's break down the 5 interconnected constructs of this model. It starts with A, cultural awareness. So what does that really mean for a nurse in practice?
Well, it starts with recognizing just how profoundly culture impacts patients' health values and when, or even if, they seek care. But crucially, it also involves nurses looking inward, acknowledging their own cultural biases, their own ethnocentric tendencies.
So realizing my way isn't the only way, or even the right way.
Precisely. Realizing that your norms are often cultural, not universal. And understanding, too, that many of our standard evidence-based practices were developed based on studies done primarily with people of European origin, so they might not automatically apply universally.
That's a big one.
Yeah. It also means recognizing that in any healthcare encounter, there are really 3 cultures intersecting: the patients, the nurses, and the culture of the healthcare setting itself.
Ah, okay.
And as patient advocates, our job is often to help negotiate that, to support the patient's cultural needs and preferences within that system.
Got it. Okay, next is B, cultural knowledge. How do we gain this?
Lots of ways. You can attend cultural events, build friendships with people from different backgrounds, participate in in-service programs at work, do your own reading, explore reputable online resources.
It's about actively seeking out information.
Yes. And this knowledge helps us interpret behavior more accurately, build rapport more easily, ask the right kinds of questions during assessment, and identify those cultural variables that are important for care planning.
So knowing about different worldviews, nonverbal communication styles, etiquette, family roles, Views on mental health.
Exactly. Health and illness patterns, cultural syndromes, those pharmacogenetic variations we talked about, even common folk or herbal treatments patients might be using. Knowing a bit about Vietnamese culture, for instance, might give a nurse valuable insight into Mrs. Lee's family dynamics or health beliefs.
Okay, that makes sense. That leads us to see cultural encounters. This sounds like where the rubber meets the road, putting knowledge into
Pretty
practice.
much. The model emphasizes that having multiple encounters with diverse patients is vital. Why? Because it helps prevent stereotyping.
Ah, because you see the variation within a culture.
Exactly.
Yeah.
Individuals within any culture adhere to norms in very diverse ways. These encounters also build your confidence and skill in interacting across cultures.
But what if you mess up? Say something wrong.
You will. Nurses will make cultural blunders. It's inevitable. The real skill isn't avoiding them entirely, but learning to recognize when you've caused cultural pain, that discomfort or offense a patient might experience because of something you did or said.
And then,
And then you recover. You acknowledge it, maybe ask what caused the offense, apologize sincerely, and express a genuine willingness to learn. Admitting you don't know everything, being humble, actually builds trust. It doesn't destroy it.
that's really helpful. Okay, fourth construct, decultural skill. This is about actually doing the assessment sensitively. What's the absolute first step here?
Ensuring meaningful communication. We keep coming back to this, but it's that important. If the patient, like Mrs. Lee, isn't fully proficient in English, you must engage a professional medical interpreter. No shortcuts, no exceptions.
Okay, interpreter secured. Then what? How do we actually perform this cultural assessment?
Well, beyond using tools like the DSM-5's cultural formulation interview, the book mentions a classic set of questions from Kleinman and colleagues way back from 1978 that are still incredibly useful.
Okay, what are they like?
They're designed to elicit the patient's perspective, their explanatory model of their illness. Questions like, what do you call this illness? Or, what name does it have? When do you think it started? Why then? What do you think caused it?
Getting at their understanding.
Exactly. How does the illness work? What does it do to you? How long do you think it will last? Is it serious? And crucially, how have you treated this illness so far? How do you think it should be treated?
So for Mrs. Lee, instead of just asking, are you depressed, you might use these kinds of questions to understand her experience of the headaches and fatigue.
Right, maybe asking, some people experience sadness when they have these kinds of persistent headaches. Has that been true for you at all? It opens the door gently.
And the book stresses how to ask these questions, doesn't it? Using a conversational, maybe indirect approach.
Yes, absolutely. Instead of directly asking, what do you think is wrong, which might feel confrontational, you could try, what does your family think is wrong? Why do they think it started when it did? What do they suggest you should do about it?
And then you can follow up with, do you agree with them?
Exactly. It respects potential group orientation. Another technique is using declaratory statements to make it feel safer for the patient to share, like saying, sometimes people have remedies or healers they find helpful when they're ill.
Huh.
Are there any special healers or treatments that you've used for this or perhaps that you think might be helpful now?
That feels much less like an interrogation.
It does. And other areas to pay special attention to during the assessment include ethnicity, religious affiliation, any spiritual practices that are important, dietary patterns or needs, their attitudes about pain, past experiences, good or bad, with Western medication.
Cultural remedies they might be using, who they consider family for making decisions, and any specific customs they're worried about violating while in the hospital or clinic.
It's about getting that holistic picture, really understanding the person and their cultural context, including Mrs. Lee's family's role and her potential use of traditional remedies.
Okay, so you gather all this rich information through cultural skill. What does this mean for actually developing the care plan? The sources mention a framework, preserve accommodator pattern.
Yes, by McFarland and Wabielama. It's a really practical way to think about clinical decisions based on the cultural assessment.
So preserve or maintain. That means encouraging aspects of the patient's culture that actually promote health, even from a Western perspective.
Right. Like if Mrs. Lee has strong family support that helps her cope, you absolutely want to preserve and encourage that.
Okay, then accommodate or negotiate. This is for values or practices that are maybe culturally important, but essentially neutral from a health standpoint.
Exactly. Things like using certain folk remedies that aren't harmful or involving traditional healers. You can often accommodate these, work with them, maybe even encourage them if they build on the patient's existing coping systems. The example given is Native Americans using tribal healing ceremonies alongside conventional treatment for substance abuse.
You're working with the culture?
Precisely.
Hmm.
And finally, repattern or restructure. This is for cultural patterns that are genuinely harmful from a health perspective.
Like if Mrs. Lee was taking an herb that was known to interfere dangerously with her prescribed blood pressure medication.
Perfect example.
Yeah.
In that case, you can't just ignore it. It requires careful patient education and negotiation to find a way forward that respects the patient but ensures safety, aiming for a mutually agreeable therapeutic plan.
Okay, preserve, accommodate, repattern. That's a useful framework. Now, the final construct of the model, E, cultural desire. This sounds important.
It's arguably the most important, the foundation for everything else. It's the motivation, the want to.
So, what does cultural desire truly entail? It's more than just knowing you should be competent.
Oh, much more. It's not about acting out of a sense of duty or obligation. It comes from a sincere, genuine concern for the patient's welfare, a true desire to understand their unique viewpoint, their world.
How does that show up in practice?
It shows up through patience, consideration, empathy, but maybe most importantly, a willingness to learn from the patient, seeing them as the expert on their own experience, rather than trying to impose what you think is correct.
So it's about humility again.
Absolutely. Humility, openness, flexibility. This genuine desire inspires trust and makes good outcomes possible, even when the nurse and patient come from vastly different cultural backgrounds. It's really what transforms a technically proficient nurse into an exceptional, compassionate one for patients like Mrs. Lee.
Wow. Okay, so our deep dive into cultural implications in psychiatric mental health nursing really shows that cultural competence, it isn't some checklist you complete once and you're done.
Not at all. It's an ongoing, dynamic journey. It's a process that deeply impacts literally every patient interaction you will ever have.
By continuously cultivating that cultural awareness, building your knowledge, honing your skills through encounters, and nurturing that genuine cultural desire.
You are building not just your professional expertise for practice and for things like the NCLEX, but also the deep empathy and critical thinking skills that truly define an exceptional mental health nurse in our increasingly diverse world.
So as you continue on your own journey, maybe take a moment to consider how deeply ingrained are your own cultural beliefs about what's normal or healthy. And then think about how that profound self-awareness can transform every interaction you have, not just in nursing, but really in all aspects of life.
That's a powerful thought to end on.
Thank you for joining us on this deep dive. Remember, you're building both essential knowledge and profound empathy as future mental health professionals.